Today's topic is about the acute rheumatic fever. Acute rheumatic fever is a multi-system disease resulting from autoimmune reaction to infection with group A streptococcus. Acute rheumatic fever and resulting rheumatic heart disease are diseases of poverty. Now, if we talk about the incidence and the epidemiology, in the developing world, its incidence is almost 200 per 1 lakh populations, but in the United States its incidence is 1 per 1 lakh population. But why this much difference is there? Because it is due to improved public health, living conditions, development of modern antibiotics, and shift of endemic strains of group A hemolytic streptococcus. Rheumatic fever is more common in military recruits, close contact with school-age children, and in persons of low socioeconomic status. Rheumatic fever is most common in between 5 to 14 years of age and is rare in persons whose age is more than 30 years. Rheumatic fever affects both male and female equally, except in Sydenham's chorea, which is more prevalent after puberty. Let's talk about the pathology. Acute rheumatic fever almost occurs nearly 3 to 4 weeks after throat infection with group A hemolytic streptococci, especially serotype M. The pathology is mainly due to antigen mimicry, because here the antibodies that are formed against the protein and carbohydrate in the cell wall of group A streptococcus, they actually cross react with proteins in the cardiac valves. These antibodies bind to endothelial cells on the heart valve and they activate VCAM1. Those activated lymphocytes are recruited and leads to lysis of endothelial cell in presence of complement system, and they activate cross reaction with release of T cells and ultimately invade the heart. Some other tissues are also involved in this disease. These are the involvement of connective tissue in joints that leads to arthritis, involvement of caudate nucleus in brain that produces Sydenham's chorea. Now, in case of heart involvement, the most common involvement is on the pericardium that leads to pericarditis. In the myocardium, it leads to myocarditis that may produce heart failure and arrhythmia, and the involvement of endocardium that leads to endocarditis that involves mitral valve in 65 to 70% times, and the other valves that are involved are aortic valve in 25% cases and tricuspid valves in nearly 10% cases, but never in isolation. Ultimately, all the layers of heart develop perivascular focus of eosinophilic collagen surrounded by lymphocytes, plasma cells, and macrophages. These are called Ascoff bodies. Actually, the damage to the tricuspid and pulmonary valve is usually secondary to increase in pulmonary pressure due to left side valvular heart disease. Now we come to the clinical features. The clinical features, there is usually a latent period of almost 3 weeks between precipitation of group A streptococcal infection and the appearance of clinical features of acute rheumatic fever. The first symptom that we consider here is a sore throat. Nearly 40 to 60% patients complain about it. These patients usually have upper respiratory tract infection in preceding 3 weeks ago. Patients with rheumatic fever also presents with some constitutional symptoms like fever that is usually between 101 degree Fahrenheit to 104 degree Fahrenheit, malaise, weight loss, pallor, arthralgia, and epistaxis. Third is the joint involvement, that is polyarthritis, and There is a symmetrically involved large joints like knee joint, ankle joint, elbow joint, and wrist joint. The migratory involvement. Joints are swollen, they are tender, they are warm and red. That's a sign of inflammation. And on rare occasions, periarticular fibrosis occurs in rheumatic arthritis. It is called Jacquard arthritis. Fourth is the carditis. It occurs in 30 to 60% of cases, commonly occurs in young children. It ranges from asymptomatic presentation to progressive congestive heart failure, and ultimately that leads to death. The symptoms that will characterize these conditions like shortness of breath, dyspnea on exertion, cough, paroxysmal nocturnal dyspnea, chest pain, and or orthopnea. So what are the signs of carditis? They include development of new murmur, cardiac enlargement, congestive heart failure, pericardial friction rub, and or pericardial effusion. What are the characteristics of murmur? Here the murmur is high pitched, blowing, hollow systolic, apical murmur. That's typical presentation of mitral regurgitation. There is a low pitched apical mid diastolic flow murmur that is also called Carey-Coombs murmur. It is due to relative mitral stenosis, and also a high pitched decrescendo diastolic murmur of aortic regurgitation. Actually, if there is an early valvular damage, that will lead to regurgitation, and over years, if there is recurrent episodes, then it may lead to valvular stenosis. Therefore, carditis in previously unaffected individual ultimately leads to mitral regurgitation, sometimes associated with aortic regurgitation. Fifth point is the pseudonym chorea. There is usually a latent period of 3 weeks between precipitation of group A streptococcal infection and appearance of clinical features of acute rheumatic fever. But in this pseudonym chorea, there may be a prolonged latent period, almost up to 6 months. It occurs mainly in children, rare in adult, but more common in girls. It occurs with other symptoms of rheumatic fever or as an isolated finding, and the occurrence as an isolated finding is more common. The initial manifestations of pseudonym chorea are difficulty in writing, difficulty in talking or walking, and a characteristic darting movement of tongue. And the symptoms usually become evident when patient is under stress or awake but disappears after sleep. Sixth is the erythema marginatum. It occurs in nearly 10% of patients. Erythema marginatum is characterized by non-pruritic, painless, serpiginous, evanescent macular rash having the pale center that tends to disappear within a few days. What is evanescent rash? It means the rash that appears and disappears before examiner's eyes. We can see that the rash sudden appears, then after some time it disappears. That is, it not continuously visible to our eyes. These rash commonly occurs over the trunk, but not on the face. These type of rash may be induced by heat. Seventh point is the subcutaneous nodules. These occurs in 20% of rheumatic fever patient. These are usually 0.5 to 2 centimeter, firm, painless, freely mobile nodules that are found in clusters. They are mainly found over extensor surface of joints like knee joint, elbow joint, and wrist, and over the bony prominences, tendons, dorsum of foot, occipital regions, and cervical processes. Skin overlying the nodules is freely mobile and shows no sign of discoloration or inflammation. It lasts for a few days and then disappears. 8 point is a fever. Although high grade fever more than or equal to 39 degrees Celsius is the rule, but a low grade temperature may occur. Now we come to the main uh, diagnostic criteria of acute rheumatic fever, that is the Jones criteria. It is as per the World Health Organization that in 2015 Jones criteria has been revised, so we call it revised Jones criteria. What is it? There are diagnostic categories and some criterias. First point is the initial episode, that is acute rheumatic fever diagnosis. Then second is subsequent episode, that means recurrent attacks of rheumatic fever in a patient without established rheumatic heart disease, and the recurrent attack of rheumatic fever in a patient with established rheumatic heart disease. The low risk populations and high moderate risk population. So what are those? Low risk populations are those in which acute rheumatic fever incidence is less than or equal to 2 per 1 lakh school age, that is 5 to 14 years, or all age rheumatic heart disease prevalence of less than or equal to 1 per 1000 population per year. And the moderate to high risk population are those children that are not clearly from a low risk population. There are various criteria. The major criteria are carditis, that may be clinical and or subclinical. The term subclinical has been revised in the revised Jones criteria. What is meant by subclinical? That is, it is seen only on echocardiography without auscultatory finding. So first is carditis, the second is arthritis, third is chorea, fourth one is erythema marginatum, fifth one is subcutaneous nodules. And among the minor criteria is clinically fever, that is more than or equal to 38.5 degrees centigrade. There is polyarthralgia. As per laboratory finding, there is elevated erythrocyte sedimentation rate. Electrocardiogram shows prolonged PR interval. So for the initial episode, for the acute rheumatic fever diagnosis, the criteria is 2 major or 1 major and 2 minor manifestations plus evidence of preceding group A streptococcal infection. For subsequent episode in which there is recurrent attack of rheumatic fever without a stabilized rheumatic heart disease, the criteria is same as above, but for recurrent attack of rheumatic fever in a patient with established rheumatic heart disease, the criteria is 2 major or 1 major and 2 minor or 3 minor manifestations plus evidence of preceding group A streptococcal infection. Now there is some differences in the major and minor manifestations in the low risk populations and the high to moderate risk population. And now the major criteria that are equal in both type of populations, these are the carditis, that may be clinical and or subclinical, chorea, erythema marginatum, and subcutaneous nodules. But the arthritis in case of low risk population is polyarthritis, but in high to moderate risk population there may be monopolyarthritis or polyarthritis or polyarthralgia. In case of minor manifestations, those that are equal in both type of population are the clinical fever, that is more than or equal to 38.5 degrees centigrade, and the electrocardiographic findings, that is prolonged PR interval. Now the polyarthralgia is found in low risk population, but in case of high to moderate risk population there is monoarthralgia. Also, the erythrocyte sedimentation rate. In case of low risk population, the ESR value is more than or equal to 60 millimeter in the first hour, and the C reactive protein that will be more than or equal to 3 milligram per deciliter. In case of high to moderate risk population, the ESR value will be more than or equal to 30 millimeter in the first hour, and or the C react. Now there is also a category that says that there should be a supportive evidence of preceding streptococcal infection in the last 45 days. And for this category, the criteria is elevated or rising ASO titer or other streptococcal antibody, or positive throat culture or rapid antigen test for group A streptococcus, or recent scarlet fever. As per the Harrison 20th edition, the tests that are recommended for all cases, these are the white blood cell count, erythrocyte sedimentation rate, C reactive proteins. If there is a febrile case, then the blood culture should be done. The electrocardiogram that should be repeated in 2 weeks and 2 months. If there is a prolonged PR interval or other rhythm abnormality. Chest X-ray if clinical or echocardiographic evidence of carditis. Echocardiogram that should be repeated after 1 month if the result is negative. Throat swab culture, preferably before administration of antibiotic. And anti-streptolysin serology, both anti-streptolysin ASO and anti-DNS B titer if available. That should be repeated in 10 to 14 days later if the first is not confirmatory. Now, what are the tests for alternative diagnosis depending on the clinical features? We should do repeat blood culture if possible. Endocarditis is there. We can take joint aspirates, both microscopic and culture, for possible septic arthritis. Copper, ceruloplasmin and ANA, and the serology and autoimmune markers for arboviral, autoimmune or reactive arthritis. On the radiographic findings, we will find the increased cardiac size, increased pulmonary vasculature, and there is pulmonary edema. The electrocardiographic findings are the sinus tachycardia, prolonged PR interval, and the low voltage QRS complex, as well as ST segment changes in acute pericarditis. In case of echocardiography, there may be evidence of mitral regurgitation and evidence of aortic insufficiency. So this is all about the acute rheumatic fever definition, pathology, clinical features, and the criteria for its diagnosis. In the next video, I will discuss about the treatment guidelines and the prophylaxis for the acute rheumatic fever. Thank you for watching the video.